think we can get started. Welcome, everybody. I am pleased to welcome Dr. Mariam Aboian to our first lecture. She is an assistant professor of radiology at the Children's Hospital of Philadelphia here in the University of Pennsylvania. She is the lead investigator of the Aboian lab, which is called Imagine Quant, that most of you are familiar with, that you've worked with. She has spearheaded the 2023 and 2024 BraTS challenges, and she is now at the helm of the BraTS 2025 Lighthouse Challenge. Today, she will be presenting on standardized and advanced reporting in brain tumor imaging. Standardized reporting, as you guys know, is essential for report quality, and it helps radiologists communicate with clinicians better and impact patient decision-making better. Thank you so much for being here, and we can get started.
Thank you so much, Raisa. I'm excited to present. Are you able to see my screen?
Yes.
Excellent. So we're going to be talking about standardized reporting in brain tumor imaging, and we will focus on brain metastases. So the problem that we have with imaging is that we are mostly focused on qualitative imaging interpretation. Here's a great example. This is a 6-year-old child with pielomyxoid astrocytoma undergoing chemotherapy, and I used an image from CHOP website to demonstrate the human aspect of radiology, that we're not just treating images, we're actually treating patients here. So just move this away. I don't know if you guys can see the little window. So this child has a suprasellar mass that is heterogeneously enhancing. And at presentation, we were able to do a 2-dimensional measurement. And this is actually a real measurement from clinical PACS that was reported in the radiology report. And you can see that the tumor is actually heterogeneous, but the measurement is a little off, and it doesn't even have the perpendicular cross-sections of measurements. But this is what is being used for this child in establishment of baseline of the tumor. This patient was started on therapy, and we will follow this patient over time as they're being tracked with imaging. Here's several months later after the therapy was started, and we were comparing the imaging qualitatively and then semi-quantitatively using this measurement. So if I ask anyone in the room, are these measurements the same? And I would love to ask whoever is in there. Let's ask Athanasios, are these measurements the same? Are they truly providing the kind of evaluation for this child that allows us to assess whether the tumor is shrinking or not?
Well, I think from these two measurements, we cannot have a clear picture of that, because they are not the same. Yeah.
And do you think these measurements...
Segmenting would be helpful here, as we do
with brain metastases. Yeah. And do you think, in addition to segmentation, if we don't have segmentation available, would you want another measurement to be included? Sort of like a craniocaudal measurement that could provide a little bit more information, but still be inferior. Agree. How about here? This is another several months later, and this is a real clinical measurement. What do you think is the difference between this and the other two cases? Let's just stick with Athanasios here.
Well, I see that there is probably a cystic part. And is this post-treatment or pre-treatment?
This patient is being treated, yes, for pilocytic astrocytoma with chemotherapy, which is fairly toxic.
Yeah.
So we're measuring a cyst and not even measuring the solid anymore, right? And we're reporting a completely different component of the tumor versus here, we couldn't even find a cyst, so we weren't able to measure that. This is another several months later. Here we're measuring, what do you think we're measuring here, Athanasius?
Probably the whole tumor area, post-cystic and enhancing parts of the tumor.
Exactly.
All except the edema.
Exactly. But how does this measurement compare to this measurement?
To the third measurement.
Yeah, very different, right? One is complex cystic and solid, and the other one is solid, but very, very different. How about here? These are real measurements that were on PACS. We just went to town, right? Exactly. So if you look at this stock picture, imagine a child that you're treating with cancer who has a pielomyxoid astrocytoma, which is a low-grade glioma in pediatrics. This child has a long life to live, thankfully. And we're following them on chemotherapy over time, and we're using these kinds of measurements. Is this a fair approach towards the child in terms of figuring out how they're responding to therapy or not? Probably not. Right? And this is where including volumetrics, like Athanasios said, is really the future of imaging, but it's not available yet. This is what we're doing right now. We're eyeballing the differences in tumor size and doing some measurements based on our kind of qualitative assessment, which is good enough for big changes, but is not good enough for small changes. What about here? This is a great case of a 57-year-old male with multiple brain metastases. And this patient received chemotherapy and actually had gamma knife therapy to some of these lesions. We don't know which ones. The radiation oncologists know which one because they have it on their own separate PACS, but we don't know which one of these lesions was gamma knifed. We just know some of them were. But we have this image. We have the knowledge that some lesions are treated, some are not. This patient is going through chemotherapy, and they're actually thinking of doing further treatment. How are we supposed to interpret the scan? There's more than 100 lesions here, right? So how are we supposed to provide precision medicine to this patient to decide how to treat them? And if you look at an actual report of this study, it says more than 10 metastases intracranially, with some of the lesions getting larger, as detailed above. And maybe there's a few measurements in the findings portion of the report, and that's pretty much it. As a clinician, some of you are not going to be a radiologist. Some of you are going to be neurologists, neuro-oncologists, neurosurgeons. How would you like to get this report as your answer to the imaging problem that you see here? Is this enough information for you to decide how to treat this patient in the future? Yes, Athanasios.
Well, for me, I think it could have been much better. I mean, we don't know how much they have grown. We don't know if this is because of the necrosis. We don't know anything. Yeah. Knowing the mLs, the volume, I mean, from this lesion and being able to do a percentage of the growth, it would be much, much better.
Exactly. So knowing which lesions were treated, which ones got bigger, which ones got smaller is important because that will allow us to provide precision therapy to this patient. But unfortunately, the tools haven't always been available for that. Also, brain metastases are heterogeneous. You can have tumors that can be very large with lots of edema. So you can have a brain metastasis that's smoothly enhancing with lots of edema surrounding, and they're usually at gray-white interface. And this is the T1 postgad, and this is FLAIR. And you can also have something hiding, like right here, tiny small metastasis in the basal ganglia, like right at the caudate. But you can also have white matter changes without a metastasis there. So we need to be able to interpret all of the modalities of the imaging. You can also have tiny little metastases that are really hard to see, such as you see right here, a 1 millimeter, 2 millimeter, 3 millimeter metastasis. And here's another one. And hey, guess what? Here's another one. Really hard to see. And on FLAIR, they don't always show up. Sometimes, like this one, is not showing up on FLAIR because it's right kind of like on the dura area. Or you can have giant ones with central necrosis and peripheral enhancement, lots of edema and midline shift, but also looking like a glioblastoma. So we're not able to differentiate whether this is a brain metastasis or glioblastoma. So approach to brain metastases is complicated because imagine doing a two-dimensional measurement of this tiny guy. That's going to be really hard. Or a two-dimensional imaging of this one is easy, but then you're measuring both the necrotic and solid portion. Which one should you be measuring, right? Here, it's fairly straightforward. You can do the two-dimensional measurement like we did above. So whereas preoperative brain metastases are complicated, the postoperative brain metastases are even more complicated. This is a case that I saw as a fellow. This patient had a breast cancer metastasis to the right cerebellar hemisphere. So you can see it right here. This is the cerebellum, and this is the right cerebellar hemisphere, and this is the metastasis. This metastasis was treated with gamma knife. And
I can't see a pointer.
You can't see my pointer. Can you see my pointer now?
I can't.
Oh boy, I don't know how to do a pointer in Teams then. Do you want me to try to, yeah, I don't know how to, I guess I could share the entire screen. What do you think that's going to help?
That might help, yes.
Yeah.
Okay, so just see. Does this help?
Yes.
Okay, perfect.
Thank you so much.
So thank you so much for notifying me. So here's the brain metastasis in the right cerebellar hemisphere. And you can see, as Athanasios actually was pointing out earlier, that it's not a homogeneous enhancement. It's actually kind of elongated lesion with a central hypoenhancement. And this is fairly classic for post-treatment brain metastasis. The only problem is we don't know how much of this lesion is post-treatment changes and how much of it is recurrent tumor. And we can try to look at other imaging modalities, such as on FLAIR, you can look at edema. On, I'm sorry, this is T2. On T2, you can look at hypointensity within the center of the lesion. On diffusion-weighted imaging, you can try to see if there's any reduced diffusion to indicate cellular tumor. On ADC, you can look if there's any low ADC values, and here they're all high ADC values, indicating the majority of this lesion is post-treatment changes. You can look at susceptibility-weighted imaging and see if there's any blood products in the lesion. So the blood products you can see right here are indicating that there's some post-treatment changes, and they correlate to hypointensity on FLAIR and T2. And then you can also look at perfusion at cerebral blood flow on ASL and see if there's elevated CBF within this lesion that would indicate cellularity. And in this particular case, on additional sequences, we're starting to see that majority of this lesion is actually post-treatment changes. But what we found out as we followed this patient for 5 more months, this residual small amount of tumor actually grew and actually was able to be detected. And when they did finally resect this lesion, half a year later, 25% of the tumor at that time of the lesion had tumor cells. So the next frontier is really being able to characterize these lesions and see how they're growing over time. And lesions that have more tumor in them are presumed to be growing faster than lesions that have less tumor. They should have more of a plateau. So these kinds of treatment response curves have potential of helping us to identify which lesion is post-treatment changes, which lesion is recurrent tumor. And this can be used in conjunction with other modalities that would indicate to us what this is, such as advanced MRI. And you'll receive some lecture topics on advanced MR sequences that we can use. So the idea is to start introducing individual lesion tracking over time and see how the lesions are changing. So if it's just post-treatment changes after resection, the lesion will decrease in size and will stay very small. Or in a lesion that's growing, that's recurring, and you do gamma knife, then it should go down and then stay at a plateau, and that's a treated lesion. That's cured focal cancer, right? So that's wonderful news. Or you could have another lesion that also got gamma knife and stayed focally at a plateau. Of course, over time, as you follow them, some of these lesions will recur, and then you will have a growth that you will start seeing. But being able to see this kind of granular quantitative data based on your imaging really helps, as opposed to just seeing this kind of a report, which doesn't really help you because you don't know which lesion got treated. You don't know which lesion got bigger, got smaller, and all you're getting is just a big picture. And the next thing you're going to do is probably do whole brain radiation therapy, or you're done with that, or try to do chemotherapy if this cancer is susceptible to specific targeting agents. But if you're able to track individual lesions, and some of them are getting bigger, and you can actually target those lesions with gamma knife, or you can devise a specific treatment plan that will focus on the lesions that are growing and leave the lesions that are stable alone. So this enhanced report prototype is not new. The idea for this is not new. We've been talking about this for years, but it just hasn't been implemented yet. When I was working with one of the vendors, we actually had this prototype for lesion tracking available. It's called Lesion Tracking Tool. And this is a great example of how we use the lesion tracking tool in helping the care of a 7-year-old child. This child had leptomeningeal brain metastases. And on this MRI that we were reading, you can see that there's one lesion here. It's right at the leptomeninges area. Here's another one, right? They're hard to see. But then there's another lesion that we're not really sure what it is, but if you look at it, it's actually a cortical vein. You really need to scroll up and down to be able to see that. Now, to see how this patient is responding to therapy, we need to compare to a prior, and hopefully multiple priors. But usually, because we don't have that much time to read the studies, we have to compare mostly to one prior in detail, and then superficially to more distant priors. So here's an example of a prior. Unfortunately, on this prior, the patient was moving. So we don't have a good prior to compare to, but we still tried. So we compared this lesion to this lesion and found that maybe about the same, maybe a little bigger, not sure. Here's another lesion. Oh, that looks like new lesion. So the report went through, and there's more than 30 lesions in this patient. That there's interval increase in size, number, and enhancement of these metastases, measuring up to 8 millimeters in size. And there was no additional complications. So the oncologist reached out in tumor board and asked, hey, I think the patient's doing well on their chemotherapy. Clinically, they're doing great. But the radiology report is suggesting that there's disease progression. What's going on? So we went back and we actually measured every single one of these lesions using a lesion tracking tool. So we were able to compare the current study to a prior study and put it in a lesion-based report. And here we have lesions 1 through 10, and the lesions keep going. You can scroll back and up and down. And what we noticed is that when we actually slowed down and measured one lesion at a time and compared them to prior, they were not really changing significantly in size. So this child did not need new therapy. But if we just compared them side by side and used qualitative assessment and not do the measurements and not force ourselves to really compare the sizes by measurement, we call progression. But after doing this kind of reporting, we actually got growth curves that are fairly stable overall in terms of the disease. So this child did not need new therapy. And if we use the RECIST criteria, which in this particular iteration of the report, we were able to see that there wasn't any bypass of the stable disease. So here we use two different approaches. One reporting that's quantitative based, that focuses on each individual lesion. It gave us one result. And the other one is a qualitative method where we just eyeballed the lesions and measured a few of them, and it gave us progression of disease. And you would think that's not a big deal, but it is a big deal. This is a child's life. This is a chemotherapy that's fairly toxic, that can affect their life, can affect their side effects, can affect their cognition in the future. So when we're deciding to change chemotherapy, we need accurate information, not eyeballing information. But that's just the state of the practice right now, because these tools are not always available in clinical practice, and not everyone is able to use them. Now, in my practice, this tool was clinically available. And unfortunately, it wasn't built for brain metastases. It was built for lung cancer. So it wasn't using the right response criteria. The response criteria for brain metastases would be based on the RANO group for brain metastases. And as you can see, partial response is classified in greater than 30%, equal or greater than 30% increase in some longest distance relative to baseline. And usually it's just a single measurement. It's not a cross-sectional measurement. And then you identify several target lesions and you measure this assessment, and that's how you define it. There's no volumetric option here yet. The RANO is suggesting that you can start using volumetrics, but it hasn't been established. So we're using these fairly old criteria for measuring lesions, and that's how we're defining tumor progression or stable disease or partial response. So, which are very important categories in deciding how we treat patients. Now, this problem was recognized really long ago by Dr. Folio and many other investigators. And as you can see, this is one of his papers from 2013 that addressed this in lung cancer. And he has built this PACS at NIH and has shown that measurements using PACS-based tools improves turnaround times. So this was done really long ago, and it's still not in clinical practice. It's just recently that it appeared in our PACS on the clinical side and not really at other PACS. Why is it not adapted yet? And why, even with availability of this tool in my practice, I was the only neuroradiologist using it? So the truth is, it actually takes time. So we actually published a paper on using this tool showing that it adds value. We didn't focus on adding time. It adds value when you compare to multiple priors. So we really looked at 7 priors and compared them to current, and basically showed that the number of clicks decreased in terms of being able to use this tool, and mostly it was based on loading of the images. These were manual measurements with this organizational tool, no AI involved. So we showed improvement in turnaround times, but we didn't really see improvement in time. what we did see that there was value. So in brain metastases, RANO-BM, there's progressive disease category. What we found is that in the progressive disease category, we had two types of lesions. One where a patient would have multiple lesions and majority of the lesions were staying the same, but one lesion was growing. This particular patient would need therapy only to this particular lesion, and they would just need targeted therapy for this lesion. Versus in the other case of progressive disease patients, they would have multiple lesions and they're all growing. Now, this particular patient would require completely different therapy than this patient. So in RANO-BM, they're all in the same category. But if you use these treatment response curves, you'll be able to differentiate this patient. Now, in clinical practice, in the report, the word report that is available at the end of the image interpretation, we really just compare this time point to this time point. We don't include these other time points because it's just not physically feasible to compare that many studies. We have to rate many studies in one day. So we can really just go to most recent prior, and then we try to compare for the other lesions more distant. So this creates a possibility of error where we're missing cases like this, or and bundling them all into one category, and that can affect patient management. So in this manuscript, we showed value of lesion tracking tool. Now, most recently, I've been working with actually one of your colleagues, David Weiss, who came to my lab from Germany to do research with me. And he actually incorporated a unit-based algorithm into this lesion tracking tool. So we no longer were measuring manually. We're actually automatically segmenting the brain metastases. And what he showed is that the time from full measurement of current study and 7 priors, or depending on how many priors they had, actually, we normalized to the number of priors here, was significantly cut if you used the AI tool. So here, from the longest time, we could go from 24 minutes to 3 minutes based on measurements. So whereas 24 minutes, no single radiologist is going to be doing those kinds of measurements for 24 minutes. To perform the full assessment of the cases and all the priors. But a 3-minute measurement, that will be used in clinical practice. We also, what David showed is that number of clicks has significantly decreased, which, as you may know, or although you may not know because you're still very early in your training, we use a lot of clicking for imaging, and that can create problems with hand health. So you can develop carpal tunnel and those kinds of things. So the number of clicks has decreased significantly, which allows us to have a more ergonomic approach to medicine, to radiology. And he's done this for 2 neuroradiologists, neuroradiologist 1 and neuroradiologist 2. So he has shown that there's statistically significant difference in time and number of clicks when you use an AI-based tracking of brain mets. So not only do we have value to tracking individual lesions, we also have time savings and workflow savings, which are great for hospitals. So when you're thinking about translating AI into clinical practice and improving reporting of brain tumors, you want to be thinking about model development and clinical impact. And there's a gap between model development and clinical impact. And this gap includes multiple factors such as validity, usability, and utility of this model that can translate into clinical impact. And what we're proposing is that PACS is a critical component of this, that being able to incorporate it into the platform that we actually use on clinical practice really translates model development into clinical impact, in addition to these important assessment metrics that we need to perform on the algorithm. So I actually got involved in this because you are starting out in medicine, I want to tell you a little bit about my journey as a junior faculty and how I started working on this. Because overall, I'm a geneticist, actually. I'm a yeast geneticist, not a computer scientist. And I started my lab about 4.5 years ago. So I don't know everything, and I'm walking this journey very similarly as you are walking. And I got on this journey when I saw how our particular hospital's PACS was able to develop a breast density algorithm and incorporate it into clinical practice using AI. And I was so blown away by this presentation. I thought, how can we do this for brain metastases? And most of the time when you have these ideas, you say, okay, that's too hard. Let me just go back to my real life. But I couldn't stop thinking about it. So I decided that I need to pursue this. And I really delved into trying to figure out how to develop well-annotated data sets. Then I proceeded to learn about open science and how to make science available and image annotation available, sort of what we've been doing in BraTS for the last 2 years. Then I got involved in algorithm development, and we have multiple students that develop algorithms for segmentation of gliomas and brain metastases. I also got involved in grant writing, and it was really fascinating because our work eventually got debuted at RSNA 2024, not as a scientific presentation, but as an actual product, which is very exciting because other radiologists will be able to use this. And the next step that we're trying to go is from prototype to products, because we really want to develop algorithms that will be used in clinical practice for everyone. So we went over the enhanced report prototype in terms of how we can measure these lesions with AI. We can list them in the template in terms of lesion by lesion measurement. And you can actually look at individual images of the lesion based on clicking on them. And then we can also track how they're responding. And versus we've done this in one PACS, but this idea can be translated in multiple PACS. And what we're doing right now is developing a clinical trial that will evaluate this in clinical practice, and we've been trying to submit that as a grant. So what problems did we encounter in doing this? And this is actually where the Lighthouse challenge is coming in. What David was really astute to identify is that he recruited 2 neuroradiologists, and he did exactly what you're about to do. He sat with the neuroradiologists as they were doing the annotations manually on 40 patients, actually. And what he found is that there was actually pretty significant inter-rater variability between the radiologists. And these were board-certified radiologists. So one radiologist would report a certain amount of lesions, and another would report certain different amount of lesions. So if you have heterogeneity between different readers, how are you supposed to provide standardized treatment to patients and precision treatment to patients, right? That's hard. When we went back and figured and looked at the cases that were not the same between the 2 readers, we actually found that the lesions were these tiny little guys, really hard to identify. So one radiologist would call it a lesion, and another would say, I think it's too small to be called a lesion. And these are the ones that are problematic that we need to figure out how to solve. But for that, we need standardization. And David's about to publish this, so please don't submit it, but don't share it yet. But in the next few weeks, we'll be planning to submit this. So we're almost there. We have the idea. We have the process for how we're going to produce the reporting that will provide value to patient care. But how do we translate it to an actual product? And this is where MICAI comes in. And the reason is, just because we develop a data algorithm on one data set for one hospital doesn't mean that another hospital's data will work for this algorithm. The algorithm may not be able to detect the lesions as well on a different protocol. We need to train our algorithms on multiple different data sets. So what was done over the last several years, we recruited data sets from multiple different hospitals, and we've curated, and you guys have been involved in annotating them. And we are actually almost done annotating all of the data. I think there was like 69 more cases left, and you guys are finishing them up, and then we're done. So that's really exciting. But one thing we've learned as during this annotation process is that there was a lot of inter-rater variability similar to what David saw. And this is where the MICI Lighthouse Challenge came up. In December, we submitted a proposal for the MICI 2025 Lighthouse Challenge, which happens to be in Korea. And these are very competitive challenges. They're really hard to get. And we were selected to be part of it. So one of the main focus for this Lighthouse Challenge is to address the inter-rater and intra-rater variability in ground truth annotation of data. And this is where we're about to start this new challenge, and I'm hoping you guys will get involved in it, because this will be the groundbreaking data set that has never been published before in the kind of rigor that we're proposing. But the benefit of doing this is I'm hoping all of you will get to go to Korea for the MICI 2025. So we're planning to present this data at this MICI 2025 South Korea. And the idea is to provide this very rigorous data set that will be not only used for our challenge and for our publication, multiple publications, but also will be highly cited by other papers that use this data set in the future. The way we designed it is we will have blocks. So this is an example of a block. Each block will have two annotators, annotator 1 and annotator 2. For each of the annotators, they will segment 25 cases. We will choose 5 from different institutions randomly, and it will be done over a 4-week period. In week 1, annotator 1 will segment lesions from scratch under video surveillance. In week 2, they will segment the same cases, lesions from scratch under video surveillance. Hopefully, the reason why we separated them between week 1 and week 2 is to give the annotators a chance to forget the studies. In week 3 and 4, the annotators will just refine the segmentation from pre-segmented NNUNet cases, also under video surveillance. All of these sessions will be video recorded without the audio, just video recorded. During the session, a student coordinator will work with a neuroradiologist as a pair, and they will go through the cases and segment them. While this is happening, the neuroradiologist
feed it to train it.
Great point. So we are using only 4 sequences as part of the BraTS challenge. So we're using T1 pre, T1 post, flare, and G2. So we'll only be using 4 sequences. In the future, as this challenge evolves, we're hoping to recruit that data sets with more sequences. Yes, Athanasios, you have a question.
Well, I have also a little technical question. I wanted to ask if this AI helps only with segmentation, or how does this AI models that David made track the METs? I mean, do they track it with the diameter, or are they doing volumetric measurements?
So the one that David did, we did volumetric, but it extracted the diameter because that's what's commonly used in clinical practice. But that's a separate project that we were doing with our local PACs. With what we're doing with Mikai and Brad's challenge is completely separate, where we will be making all these algorithms publicly available that the challengers participate in. The data that we're annotating for ground truth will be fully publicly available, and anybody who's interested in developing or even doing a startup will be able to use this data because we're making it commercially available to anyone, all comers. We're very strong believers in open science, so this is where it's critical for us to develop this. Now, once you annotate this ground truth, we will provide this at the Lighthouse Challenge, and competitors will be able to compete in designing algorithms for detecting the brain mets. Now, historically, our brain metastasis data sets have been amazingly data annotated. You guys were involved in building them. We have really great ground truth, and we've established that. But the competitors haven't been able to win our challenge very well because they keep missing the small mets. So this data set will allow them to identify new methods to identify small mets, and also will hopefully improve the detection of the metastases. And then once those algorithms are submitted, they'll be able to be published and available for different groups to use. Another thing that's really important that we're going to try to do is, so in the fall, we'll have the educational sessions through December. By different faculty. And today is kind of a hybrid of education and introduction to the challenge. But in starting January, we're going to be actually teaching how to participate in a challenge. So each one of us will get involved in Mikai Challenge for 2024. And we'll learn how to download data from Synapse, how to develop algorithms, and how to submit it. We're probably not going to win because we're beginners, but we'll at least go through the process of doing this and teach you how to do this. And we'll do it all as a group as we're learning how to do this. So that eventually you will have not only the knowledge of brain tumor imaging, and some of you will be involved as student coordinators. You'll have this advanced knowledge of brain metastases and MR imaging and all this additional kind of experience with a neuroradiologist. And I have to tell you, these are all fantastic educators and the ones we've recruited, and they're very prominent in their field. So I'm excited to have you work with them. Then you'll be involved in the challenges as well. So it's definitely something that's exciting to be involved. But if you have ideas that will help your career that we can channel through this challenge, please let us know, because we're interested in helping you succeed. And I don't always have time to dedicate to students, but in this challenge, I have dedicated time that I am able to help you. So please speak up, because these kinds of opportunities, they don't come often, and this is a great chance for you to personalize it to yourself. Any other questions? Nazarene, is this your remaining hand, or are you asking another question? Are you asking another question, Nazarene?
Oh no, my hand is still up. So, sorry.
Okay. I think we have one more question from Georg, and then I think we are that will be our last question. Georg.
Thank you very much for this extremely interesting presentation. And I have just a short question: which requirements would student participants be faced with, and which amount of neurological, neuroanatomical knowledge is necessary?
Oh, great question. Well, the major requirement is that you want to learn and that you're a nice and cordial and polite person, that you're pleasant to work with. Those are the requirements, that you're interested, organized, and polite. Those are number one requirements. In terms of neuroanatomy, you can ask questions from your neuroradiologist, and they will teach you neuroanatomy. They'll teach you optic chiasm, extraocular muscles. They'll teach you everything, thalamus, whatever you're interested in. They will go through anatomy. Neuroradiologists love anatomy. So you can just ask questions like, oh, where's mammillary body? Where's this? Where's that? Show me the tectum. And they'll be like, yes, I would love to show you. These are neurorads that love anatomy, and they will spend time teaching you while they're segmenting, because segmenting can be boring. And that's how we recruited these neuroradiologists, is by saying, you're going to be working with an interested student who wants to learn. And as you're segmenting, you're going to be teaching them at the same time based on their interests. So you'll be working with somebody who's really interested in neuroanatomy and in imaging and physics, and they'll be like, you'll be having a nice discussion over what you're doing. And if you're interested in, because each of one of you will have an individual experience, you could put together your experiences of what you learned from your sessions, and we can write up an educational manuscript, either for each individual student or as a conglomerate manuscript that will be an additional manuscript to this challenge. So it will give you more publications, or you can even present that as an abstract. So these are no big requirements. It's really just enthusiasm. All right, guys. Yeah, go on, Georg.
I just wanted to thank you.
Okay, good. All right. So if you're interested, reach out to Athanasios. He knows how to organize you guys. We will have the next session in 2 weeks, where Athanasios and Raisa will present the initiative. And Nikolai, I believe, also will present the initiative for BraTS-METS 2025 Lighthouse Challenge from the international perspective and their ideas. And this is where we'll also be getting ideas from you on what you would want from this challenge, so that we can tailor it to you as well. So they'll present their ideas, and then you can add additional ideas, and I've been adding ideas to them as well. So so let's meet in 2 weeks at noon. And I think Nikolai and Athanasios will also present their IANO abstracts work that they're presenting at the European Neuro-Oncology Society, which is a really big international society meeting. So we'll give them feedback before the meeting, and then they'll present their vision for the future. So it will be kind of like what we've done, what we're planning to do, and how we can support your careers, so that you're open. Can we take one big picture of everyone? Because I think is there a way to do like one big screenshot of everyone?
Dr. Aboian also wanted to thank you for this very informative session, and of course thank you for providing this opportunity for us trainees. We really appreciate it, and we're looking forward to be part of this challenge.
Amazing, thank you. Oh, and one more thing, I do want to highlight Anastasia, who you all know, but I just want to thank her for she doesn't get a lot of praise, which she should get, because she's truly spectacular and put this together. And I don't know, I don't see her, but she's somewhere here on the list. And thank you, Nazanin, and thank you, Raisa and Athanasios and Nikolai. I'm really grateful to you guys. All right.
Can you guys just put on your camera so that I can screenshot the the screen and everybody
Yes, please.
in it. So whoever wants to share, open their cameras, they can do it now. Yeah, yeah.
Thank you.
Let me take another shot. Okay, thank you so much, guys.
Fantastic, guys. We'll see you in 2